Good afternoon. Pleasure to be communicating with you all today. And I'm going to be speaking on a very important subject, which all of you encounter often in your practice, that is of intrauterine insemination, practical tips and tricks. Many of you do IUI in your practice. Many of you refer your patients to IUI. And for both of you, this particular talk should be of pretty significant importance. There are no secrets to success. It's the result of preparation, hard work, and learning from failure. And nowhere is learning from failure more relevant as in the treatment of IUI. Because despite years and years of experience, this particular study shows, the European registry of, from the European Society of Human Reproduction, that more than 1.75 lakh IUI with the husband semen, and the success rate, the live take-home baby rate or the delivery rate was just 8.9%. Pretty dismal success rate considering we have so many years of experience in this particular field. However, if you persist in the IUI, if you do 3 cycles or more, the final cumulative pregnancy rate does become a reasonable 40%. So you have to tell your patients right from the beginning that IUI is not a single treatment, but a series of treatments, couple of months at least. All of you, whether you actually do IUI in your clinic or not, need to prepare the patient for IUI. The American Society for Reproductive Medicine has actually recommended minimal preparation or investigations prior to IUI. They say all that you need to do is a test for assessment of ovulatory function, make sure the uterus is reasonably normal looking on sonography, test the patency of the tubes, and do a semen analysis. Ovarian reserve testing is not mandatory. Laparoscopy routinely is required only if you suspect some major pathology, and postcoital test is really not to be done. I, however, prefer to do at least one ovarian reserve testing with either typically an anti-Mullerian hormone and a baseline sonography to measure the antral follicle count, because we are seeing lots and lots of patients on a daily basis with premature ovarian failure. And you don't want to keep treating a patient and finding out later that ovarian reserve is really poor. So basic ovarian reserve test, a transvaginal sonography, hysteroscopy in patients in which there's a suspicion of any pathology, and of course a detailed semen analysis. One of the most important factors affecting pregnancy rate is the age of the patient, the ovarian reserve of the patient, and of course why she's infertile, and eventually what you're doing to treat her infertility. So all of these factors play an important role eventually affecting the pregnancy outcome and the pregnancy rate. So age, like I said, is one of the most important factors. As the age increases, the AMH declines, the antral follicle count declines, and of course, the FSH increases. So these are directly related to the outcomes of the intrauterine insemination, along with, of course, the total motile sperm count. So these are some of the most important effects upon fertility outcome. In fact, a very nice recent study showed this on older patients. This is the 4T trial, where the women were typically 38 to 42 years old. And it was found, whether you treated them with clomiphene or with gonadotropins and IUI or did an IVF, it was found that majority, in fact, 84% of all the actual live births that took place resulted from the IVF treatment. So the patients became pregnant much faster and the success rates were much higher with IVF in the older age group. So always remember that older patients don't waste much time on IUI, go on to IVF much faster. Why the woman is infertile also really affects the outcome. For example, tubal factor. If she has one tube blocked, in that also, whether it's a proximal block or a distal block matters. Patients with single tube which is blocked, but which is a distal block, have a significantly poorer outcomes than those with the unilateral proximal block. And the ones with a distal block, you're better off recommending them for IVF faster rather than otherwise. Even when you're doing a laparoscopy and you find that one tube is a little bit adherent, twisted upon itself, the angle of the twist or the bend in the tube is also important. If the tube is just a little bit bent on itself, more than 45 degrees angle, then the success rates after your laparoscopy and isolysis are much better. However, if the tube is completely acutely twisted, bent upon itself, the results, even after laparoscopic surgery, will be pretty pathetic. Endometriosis, we all know. If you have a laparoscope inside, even when there is minimal endometriosis, you must treat it. If there is a tiny cyst, unless you're doing a laparoscopy for some other reason, it's not required to treat it. So depending on what you see on laparoscopy, you may want to follow up the patient with IUI if it's very, very minimal, or in severe endometriosis, you may want to go on to IVF directly, not waste time doing too many IUIs. If there are endometriomas, it's now proven that endometriomas less than 3 centimeters, you do not need to operate. Larger than that may need surgery prior to ART. However, remember, the moment you operate on a tube, there's a significant loss of ovarian follicles, and the ovarian reserve may reduce significantly. In fibroids, there's a dramatic change in the attitude, and this very recent study shows that there's literally no difference in outcome if you remove or don't remove a non-cavity distorting fibroid, irrespective of the size. So the only indication for removal of fibroids today in almost all cases is submucous myomas. So submucous myomas, hysteroscopic removal is fantastic, gives much better outcomes. This is shown even in the Cochrane review come out recently. Even removal of small polyps hysteroscopically gives you much better outcomes for pregnancy. So these two things are the only reason why you would actually preoperatively operate on fibroids or polyps. Male factor incidence today in our practice is increasing dramatically, more than 50%. When you're offering these male factor patients, maybe mild male factor patients, IUI as a treatment, remember to tell them that 6 IUI cycles is equal to 1 cycle of ICSI or intracytoplasmic sperm injection. So a patient should be aware that IUI is not a single treatment, multiple cycles are required in male factor infertility, and maybe they'll be better off with ICSI as a treatment. So remember that if there is IUI being used for male factor infertility, it has very little chance of success if the lady is older than 35 years of age. The number of semen sperms injected is less than 5 million motile sperms, and the morphology is lesser than 30%. So you need to have a reasonably good sperm parameter before you can expect outcomes in IUI. Controlled ovarian stimulation is a significant part of the IUI, and Cochrane review and many others have shown that IUI in a natural cycle gives dismal outcomes. Doing ovarian stimulation without following it up with an IUI also gives dismal outcomes. So it's a combination of the two things which manages to give reasonable outcomes. Most of you are very familiar with the standard clomiphene for ovarian stimulation. The good thing is that letrozole has come back after a long gap, and we can now use 2.5 or 5 milligrams of letrozole from day 3 to day 7 for ovarian stimulation as an option. We can combine clomiphene or letrozole with gonadotropins, and we may or may not add antagonist. So just to recap a little bit about letrozole, the Cochrane review come out reasonably recently has shown, a very large review with 26 randomized trials, has shown that letrozole and clomiphene, when you compare them, the birth rate is higher with letrozole, whether you have planned relations, whether you have IUI, the results are better with letrozole. In fact, letrozole typically gives as good results as ovarian drilling without the risk of without the risk of twins, which happens with ovarian stimulation. So letrozole gives pretty good outcomes. The other thing, low dose gonadotropins. Most of us are a little worried to use gonadotropins for IUI, but remember that if you use a very small dose, like half to 1 ampule of gonadotropin instead of clomiphene, the results are fairly good. You get 1 follicle or 2 follicles, the endometrium is good, and the success rates are actually better. So low dose gonadotropin for IUI is a pretty good option. Or, like I said, you can combine the clomiphene or the letrozole with gonadotropins. In the latter half, you can add gonadotropins. And in fact, letrozole combined with HMG gives you the best outcomes in anovulatory or even in ovulatory patients. So that's something else which you can really use in your ovarian stimulation protocol. When you're doing ovarian stimulation, you're bound to encounter many problems. One of the commonest problems, which often is overlooked completely, is that of premature LH surge. 20% of your patients will have a premature LH surge and you won't even be aware of it. Other common problems, ovarian hyperstimulation, poor endometrium, and we'll just discuss that in a bit. So looking at premature ovarian surge, GnRH antagonist is the best way out. Rather than testing for the urine test for LH, surge, etc., just use a GnRH antagonist. It's inexpensive, easily available, small dose, 0.25 cc subcutaneous of GnRH antagonist to be started when the egg is about 13 or 14 millimeters and continue till the day of the trigger will give you complete control of the cycle, and you can even avoid weekends. You can convert that cycle to an IVF cycle without losing any benefits. So antagonist is a very good option. In fact, you can use a very, very small dose of antagonist. And this particular study released just 2 or 3 months ago says that even if you use half dose of GnRH antagonist, you'll get pretty good outcomes. So the cost will be further reduced and the outcomes will be still pretty good. Ovarian hyperstimulation, we have to be very, very careful right from the beginning when you select the patient, a patient who's PCOS, who has a very high antral follicle count or AMH, who has a history of previous ovarian stimulation. These are the patients who will cause us problems. So you be very, very careful, go very, very slow in the stimulation in these patients. Also, if the patient is showing more follicles developing, never give her HCG. If you don't give her HCG, you will not push her into hyperstimulation. What you can use is GnRH agonist as a trigger. So a small dose, 0.2 milligrams of GnRH analog as a trigger will also give you good benefits. The only thing is, if there are many eggs, multiple pregnancy risk still remains. So there'll be no hyperstimulation, but multiple pregnancy may still result. And so these patients, again, you have to be very, very careful. One important thing that we see very often, particularly when we're using clomiphene, is poor endometrial development. And there are many things that the gynecologist tries to do in order to improve the endometrium. Very often you use aspirin, you use estrogen. Unfortunately, neither of these things work. What we can do in many cases is modify your clomiphene protocol. For example, if you're using a higher dose of clomiphene, go on to just 25 milligrams. This will give you 1 follicle and a much better endometrium. Or you can start your clomiphene from day 1 instead of day 5. This again will still cause a good follicle with a much better endometrium. So modifying the dose or the timing of the clomiphene is one option. The other option is, particularly in patients with PCOS, when you're giving them progesterone to withdraw. The day you stop your progesterone withdrawal, the very next day you start them on clomiphene. So no gap, no waiting for the period. In the luteal phase, clomiphene will give you a better egg and endometrium in the next cycle. Also, if you start with 50 milligrams of clomiphene, after 5 days, if you find that the egg has not grown at all, then normally we would cancel the cycle and the next cycle start with a higher dose. Instead of that, in the same cycle, the moment you finish your 50 milligrams and you don't see a good egg, you start with 100 milligrams in the same cycle. So this is called a stair-step protocol, stepping up the dose of clomiphene in the same cycle, and you might have the ability to grow an egg without wasting an entire month of treatment. So modifications in clomiphene help. Another thing which really helps in thin endometrium in many cases is granulocyte colony stimulating factor, which is GCSF. So a small dose of GCSF infused into the uterine cavity when you find a thin endometrium on day of HCG actually helps to improve the endometrial thickness by 1 to 2 millimeters in 24 hours. Another thing that really works is sildenafil. So sildenafil in well-selected patients started right at the beginning of the cycle for up to the day of the trigger, vaginally or orally, actually helps a lot. Drugs like arginine, vitamin E may have a small role to play. Various ways of getting very minute doses of HCG or even infusing 500 units of HCG into the uterine cavity will help. So there are many simple things which you can do for improving the situation of a very poor endometrium. We hardly do much monitoring for IUI cycles, only a follicular monitoring, and then with transvaginal sonography, never really do blood levels or any other detailed testing. People are already worried about whether we should give the HCG when the egg is 16 or 18 or 20. And it has been found that it doesn't really matter. Between 16 or 18 or 20, whenever you give your HCG, ovulation will still happen. What about HCG and how many hours later should you do the IUI? People are very worried whether we should do it exactly at 34 to 36 hours. And it has been shown in this study particularly that HCG was given and IUI was done at exactly the same time. And it was found that still the results were very good compared to when you did it 24 to 36 hours later. So the timing of the IUI following HCG is not of crucial importance. Also, how many IUIs should you do? Should you do 1, 2, pre-post ovulation? And again, many studies have shown that a single IUI done just after documenting ovulation actually gives you the best outcomes, except in male factor infertility, where 2 IUIs done prior to ovulation give slightly better outcomes. So there's no need to do multiple IUIs in a given cycle. Typically, post-ovulation is the best. The best method of preparing the semen, it's pretty much documented now. The density gradient is the best method because it causes least spermatozoa damage, DNA damage, and reactive oxygen species are much reduced. So this seems to be the best outcome in terms of quality, motility, and least damage to the sperm. So most of your cases, you should do density gradient. What type of a catheter should you use? Typically, do the use of a soft catheter. Which company, which make, it doesn't really matter as long as the catheter is atraumatic. What about flushing? I think it's a good idea because there's always a dead space in the catheter. So if you actually aspirate flushing medium into the catheter, push it out, and then withdraw or draw the semen sample into the catheter directly rather than pushing it. In fact, you pull it in, it will give you a better placement and less dead space. So this is how you would flush and load the catheter. The preparation of the parts has to be only with saline, no obviously no antiseptic, betadines, nothing should be used. That would be toxic. So clean with saline and then expose the cervix in whichever fashion you want to. If you have an associate or an assistant, you can use 2 speculums. You can use a speculum anteriorly and posteriorly, or you can use a speculum and an anterior wall retractor, or you can use a Labotec or a Cusco speculum. The only suggestion is always keep a metal cannula by your side, because if the uterus is acutely antiverted, it may be a good idea sometimes to negotiate the internal loss with a metal cannula if the normal cannula doesn't pass through. So all methods work as long as the procedure is atraumatic. Also, a small tip: aspirate the cervical mucus with a syringe prior to putting in your catheter. So we do this in IVF, and doing this in IUI as well improves outcomes. Also, try to do your IUIs on a full bladder. What this does is straightens out the antiverted uterus and actually makes it in line, makes the difficulty much lesser, and as a result improves your outcomes. Another suggestion is, if you have an ultrasound machine available, do your IUI under ultrasound control. This reduces the difficulty again, and anything which is less traumatic, less difficult, gives you better outcomes. So all these modifications in a lab will help to improve the outcomes. Luteal support, most of us give it, but actually, scientifically, it is recommended only in cases in which gonadotropins have been used for stimulation. If you're using clomiphene, there may not be much need for the luteal support. So the last part is the controversy. The last part of my talk is a controversy: to do or not to do. Because recently, the Cochrane review, come out last year, has also said that there was no conclusive evidence of a difference in live birth between couples with unexplained infertility doing IUI or timed intercourse with or without ovarian stimulation. So this was quite a dramatic statement by the Cochrane review, and this actually was because of the NICE guidelines which came out in 2013. These guidelines from the UK, which are very well followed and respected throughout the UK, said that expectant management for 2 years is the best choice when the woman is quite young. And all she needs to know is when she's ovulating and keeps timing of timed intercourse during that time. And this will give you equal or better outcomes because there will be no multiple pregnancy rate as compared to IUI. And they say, the NICE guidelines said that when there has been a long period of infertility, IUI actually does not give much benefit. And this was a radical statement by them. And as a result, there was a lot of furor regarding IUI. A year ago, there was a survey carried out in the UK after the NICE guidelines to see whether people were really following this dramatic guideline or they were not. And it was found that despite the recommendations that IUI should not be routinely offered, 96% of clinics in the UK continued to offer IUI. They told their patients about it, but continued to do IUI. And so they obviously, majority of the doctors found some merit in doing IUI. And in fact, this study come out just a month ago, said IUI no more, Mr. Nice Guy, as a takeoff from the NICE guidelines, saying that even today, the live birth rates are pretty good in the first or the second cycle. So the recommendation is the per cycle probability of live birth from 21 to 5%, depending on the patient's age, cycle number, and parity. And if you persist for 1 or 2 cycles in well-selected patients, younger patients, those who've had a previous pregnancy, the results will be fairly good. So there is really no strong recommendation from other studies or guidelines about not doing IUI. Tell your patients that 1 cycle of IVF may be as effective as 3 cycles of IUI. And so patient can also decide if they're in a rush, if they've been married too long, if they're older, select other treatments. But in selected cases, IUI may still work. In fact, new predictors of IUI have come out. The age of the patient, her waist circumference, even the income level has an effect upon the outcome, how long she's been infertile, whether she had any previous pregnancy, even if it was a pregnancy loss. All of these affect the outcomes of pregnancy. So eventually, the predictive factors for pregnancy are a good patient, a good prognostic patient is one who's under 30 years with cervical or anovulatory infertility, good more than 5 million sperm count, which is motile, with 1 or 2 good eggs developing, with a good endometrium, and doing the IUI with a soft catheter. All of these things will actually eventually give you much better outcomes in IUI. So let me conclude with a word of caution. This particular study was quite an eye-opener. 246 pregnancies with ovarian stimulation and IUI, and they compared it with natural pregnancies and deliveries. There was a statistically significant difference between the groups in first trimester abortion rates, intrauterine demise rates. The perinatal outcomes were much worse with ovarian stimulation and IUI. Oligohydramnios, preterm babies, higher admissions to NICUs, etc. And so nothing is free of risk. When you're counseling your patients, tell them that there's a possibility of a slightly higher problem in pregnancy and with the fetus, or with higher morbidity after ovarian stimulation, with or without IUI. So even now, at the end of the day, IUI is the first-line treatment in subfertility. It's simple, it's effective, and it's an inexpensive procedure, and maybe a first-line treatment even today in well-selected patients. So at the end of the day, all of us are working towards giving our patients a lovely, healthy, live baby to take home. Thank you. I think we have some questions coming in, and I think after hearing this whole thing, the number of questions will reduce. So Dr. Samina Mirza has said, how do you prepare the endometrium? What would be the follow-up? So typically, if the egg is good and there is no real pathology intrauterine, then the endometrium will spontaneously grow in response to the rising estrogen from the follicle. However, if the endometrium is diseased or damaged, or has been damaged because of DNCs or some trauma or infections like tuberculosis, there will obviously be not a good response, or if there are no good eggs. So the ways and means to improve endometrium is either improve your follicle, so either change your stimulation protocol, maybe from chloroquine you can convert to letrozole, or to gonadotropins, even better, or a combination of the two things. And if that doesn't work, then there are many different remedies for improving the situation of the endometrium. In fact, the very next question also addresses this. Dr. Janak Dulari has said, what is the role of GCSF and the way of giving the GCSF? So today, granulocyte colony stimulating factor is often being used by IVF centers. And what this really does, it is actually a recognized US FDA approved molecule for recurrent pregnancy losses. So it's an immunological factor, reduces pregnancy losses, but it has been found that it also has a significant role to play in patients with a thin endometrium. So what you do, it comes as a 1 ml ampule, and you actually, on the day of the HCG, when you find that the follicle is ready for trigger, but the endometrium is poor, you can actually infuse this GCSF just like you do an IUI, put the catheter into the uterine cavity, very slowly infuse the GCSF inside, move your catheter around a little bit so that it is, there's a little air bubble there inside as well, and then you can remove it. And it can be seen that in 24 to 48 hours, very many times there's an improvement of 1 to 2 millimeters in the endometrium. GCSF can even be repeated if need be. So there is a role for GCSF, there is a role for sildenafil, and there is a role for a very small dose of HCG to be infused inside. Subcutaneous HCG, 50 units, very tiny dose, has been shown to improve the endometrium. So there are many things which you can do in cases with poor endometrium. So then we have a question from Dr. Vijayalakshmi S. I have a couple wherein IUI failed 3 times. What would be the next action? I think there is enough studies, enough nice guidelines, Cochrane reviews saying that you cannot and should not persist with IUI after a certain point. The recommendation really is, in today's times, maybe just 1 or 2 cycles of IUI. So the nice guidelines say that you shouldn't do IUI at all. You should only do expectant management, document ovulation, and tell them to keep planned relations. But many other studies after that have shown that the best success is sometimes in the first cycle, maybe even in the second cycle. But I think after 3rd cycle, there's very little role for IUI. Of course, it depends on the patient and all the other parameters. If she's very young, if all the parameters are normal and they don't mind persisting in the IUI, you could continue for a little bit longer maybe. We have a question from Dr. Vandana Charasia. How to stimulate ovary and up to what limit can various injections be given? I think we've spoken quite a lot about ovarian stimulation. So the only comment here is that in an intrauterine insemination, the ideal number of eggs is 1, maybe a maximum of 2, usually not even that. So we do not want multiple eggs because we do not want multiple pregnancies. In IUI, we cannot control that. In IVF, at least you can take out the eggs, you can create embryos, and you can put back 1 embryo. So things are in control. So in IUI, if you have more than 3 follicles, in fact, that particular cycle should be aborted or converted into an IVF cycle. So that's how your injections have to be planned in such a way that there are not too many eggs developing. Dr. T. Geeta wants to know what to do when the follicle doesn't rupture with HCG. The first thing is check your HCG batch. It's a possibility that the cold storage was not good, that your HCG isn't effective. We've seen this in IVF sometimes, that when you give the HCG and you're doing follicle aspiration from the ovary, the follicle is there, and when you aspirate, there are no eggs, or empty follicle syndrome. And then you realize we stop the cycle in between, stop the aspiration. If you do a blood test, there'll be no HCG in the blood, even though the patient says she's taken it. So there's been some problem with the HCG. Either she's not taken it properly, or the drug was not good. So that's the commonest reason. Other than that, if there is a genuine luteinized unruptured follicle, or this patient is developing cysts every time, the only solution, according to me, is to at least push her to IVF. Because in IVF, if she doesn't rupture multiple times or grows a cyst every time, you can actually aspirate the follicles and bring the eggs out rather than being unable to cause the ovulation to happen. Dr. Brijesh Kumar wants to know, is there any role of IUI in this era of IVF? What is the new development for IUI? This is actually a subject for a full presentation or a full talk I have given on the subject of is IUI obsolete? And there are plenty of studies today saying that IUI does not give much better success rates than proper expectant management, and that if the patient is infertile for a long time, IUI will not help, and that IUI may result in multiple pregnancies, twins and triplets, which is not sort of a good idea. It's very risky. And so many controversies as far as IUI goes. But at the end of the day, as seen even in the UK survey, which they did recently, despite guidelines going out in London, despite all the hype about IUI, doctors continue to do IUI, 96% of them, and they do get results, particularly in well-selected patients in the first 1 to 3 cycles. So definitely, I think there is still a role, but you have to be much more careful, and you have to counsel your patients much better about the options available to them today. So Dr. Rajesh Navangul wants to know, is it logical to give HCG on day 20 and 27 for luteal support, along with the cover of micronized progesterone? What is your experience in giving microdose of sildenafil in improving endometrial receptivity in post-IUI cases? So good question, because a lot of people like to give HCG for luteal support. I personally never give HCG, because giving HCG in the second half of the cycle, first of all, there's a possibility of ovarian hyperstimulation, and that is one chance I would never take, because we have really wonderful progesterone alternatives. We have oral, vaginal, intramuscular, subcutaneous, every possible progesterone route. So I see no reason why we should give HCG. And secondly, this HCG will interfere with your pregnancy test, which is done 2 weeks after the IUI. So I think it's really maybe not recommended to give HCG. The only good thing about HCG is it does improve to some extent the implantation rate. So if at all the HCG has relevance, it is really at the time of the trigger when the implantation is going to take place, and at that point it is of use. Later, I don't think it has much role to play. And as far as sildenafil goes, there are many studies recommending the use of sildenafil in well-selected patients and low-risk patients who have no cardiac disease, etc. So vaginal or oral sildenafil, but it has to be given in the first half of the cycle, not post-IUI. It has to be given in a patient whom you are doing stimulation. You realize she has a poor endometrium. In the next cycle, you start the sildenafil right from the beginning of the cycle and give it up to your trigger or up to the IUI or the embryo transfer. So the first half will help you actually build up the endometrium. And Dr. Meena Khatri has asked why the success rate of IUI is very low, even when the case selection and method of IUI is proper. And I'm glad to know that most people are realizing that the success rate of IUI is low, and at least they will change their practice, because even today, every single day I see doctors, offering their patients, and patients come with 10, 12 IUIs being done on them. I think that's injustice, because we have to, right at the outset, select our patients well, younger patients, good sperm counts, almost normal sperm counts, ovulatory and anovulatory, but ovulating with drugs, and no other high-risk factors. These are the only patients in whom you should do an IUI, and that too, tell them that the success rates are good only in the first or second cycle, and if you want to select an IVF, then the success rates are much higher, that 3 to 6 cycles of IUI may be equal to 1 cycle of IVF. So I think there is still a role for IUI, but it is limited, and the success rates are really not very high. So I tell my patients right from the beginning that the success rates are higher than a natural conception cycle when you're trying just naturally without any treatment, but not much better. I think we have another couple of questions coming in from Dr. Swarajya Modi Reddy. When do you say IUI has failed and ask the patient to go for IVF? In my practice, I would say a maximum of 3 cycles, because even the doctor gets pretty frustrated, and the patients start also getting very tired very psychologically upset and depressed and stressed, thinking that they will never conceive now that 2 or 3 IUIs have failed. So I would think 2 to 3 IUI failures, you should refer the patient for IVF. Even if she has just unexplained infertility, no other pathology, she will benefit greatly from IVF or ICSI rather than continuing IUI for too many times. Dr. Sangeeta Palsenia wants to know, does IUI be first resort for proceeding for ART? So I think we've discussed this so many times. For normal unexplained infertility, IUI may be a first line of treatment for 2 or 3 cycles. But then today, I think in today's times, people are moving on much faster to IVF. Dr. Unnikrishnan wants to know, what are the ethical implications of multiple attempts at IVF? I think we've been discussing IUI, and here the question is on IVF. I think the whole field of ART has many ethical questions being raised at any time. But to me, if a lady has, for example, blocked tubes, or she has, husband has severe oligospermia or azoospermia, or if she's an older patient, or she's had pretty bad endometriosis, the only option for her is IVF or ICSI. And in these patients, in fact, not offering them these treatments would be ethically wrong, or would be liable to, if you don't refer them on time, you could be subject to a litigation, because they may say that, you knew from the beginning that I would not conceive with simple treatment. You should have referred me for an IVF. So in fact, the reverse is more true. Doing IVF on patients for an average of 3 cycles is really actually a recommendation. And more than that, of course, then you have to counsel your patient that, okay, 3 cycles have failed. We don't know whether you will continue to, whether you will benefit from further IVF cycles. And maybe you can then think of changing the treatment. Sometimes you may require a donor egg or a donor embryo, or maybe a surrogacy even in certain situations. So I think at least 3 cycles of IVF you can go through smoothly. Dr. Kusum Singhal has said, what should be the exact timing of IUI in relation to the follicle? And there are studies, I had shown some of them in my talk, that even if your egg, the size of the egg is 16 or 18 or 20, and you give the trigger, the HCG trigger, the results seem to be fairly similar. So most of us give the trigger between 18 to 20, but even if the egg is 17, you will still get results. So I think you don't have to be very strict about the timing of the trigger in relation to the follicle size. Dr. Rolithor has said, how long do you ask the patient to rest after IUI? I think there is no clear answer to this, or there are not too many studies, but typically no rest is required after the IUI, because by the time you're finished with your insemination procedure, the actively motile sperms will already have swum up from the uterus into the tube, and should be ideally meeting the egg or approaching the egg which has already been ovulated. So there's really no requirement for IUI rest post IUI, just like there is no requirement for rest after IVF embryo transfer as well. And Dr. Anurag Dani has said, what treatment do you prefer for oligospermia? This is difficult, because really I am not sure there are many treatments for oligospermia. So of course, a full investigation of the male as to why they have oligospermia, lifestyle changes, reduction of smoking, if they are doing so, improving the, like some cold baths, and removing the risk factors like hot showers and tight jeans, etc. And then maybe some antioxidants, maybe some micronutrients have a role to play. So all these alternative drugs may have some role to play. Clomiphene citrate may have a small role to play. If they have bilateral severe varicocele, then maybe the treatment of varicocele, not otherwise. And so all of these can be tried. None of them are proven to have extremely good outcomes. And so eventually, if the results are not good, or if the patient has too poor account for IUIs, then direct ICSI will be the best outcome for them. So we should not be scared to accept or inform the patient that they have severe oligospermia and there is not much point in wasting time with alternative treatments. It may be better for them to move on faster to ICSI. It will give them better outcomes. I think we can finish at this point. So thank you so much for all your inputs. Thank you for tuning in. And I hope you all had a beneficial scientific session. Thank you.